Our next speaker is Patrick J. Smith. Professor Smith is an associate professor of psychiatry at UNC-Chapel Hill. His training background has focused with three primary domains: behavioral medicine, neuropsychology, and biostatistics. His work has also focused on the development and deployment of behavioral treatments within chronic disease populations. He works collaboratively with multiple investigators across numerous departments at UNC-Chapel Hill, including internal medicine, neurology, and surgery. Yes.
Thank you. All right. So I feel bad I don't have like hardly any imaging in my talk. I appreciate Paul doing a little bit of the transition to something with more clinical neuropsych. What I'm hoping is that I can use some of the things that we studied to kind of integrate. There's actually a whole lot of overlap with what I think everybody's been discussing in terms of network disruptions. So I'm really interested in this sort of interface of medical comorbidities that are endemic in the population that everybody has in older adults, how that disrupts different architecture of the brain, and how that relates in clinical syndromes that you kind of commonly see. So just to give you just the real basic crib notes, what I'm going to be talking about: modifiable risk factors, their mechanisms, how you can treat those things, and then when there's some individual differences. And I'm glad a few people touched on these. Most of this work, I should say, was with some of my colleagues. I was at Duke for many years, and Jim Blumenthal and Andy Sherwood. And most of our work, this is from the recent Lancet Joint Commission on Dementia Prevention and Caring. Most of the stuff that we do is focused in this midlife time period, so 40 to 65 or 70, what you can do to actually mitigate your risk. And when people talk about sort of preventing Alzheimer's, sometimes there's this sort of like despondence about things that we can't do in the treatments, but there's actually a whole lot that actually does seem to reduce risk at a population level, and they're the things that most of you would think about that are related to heart health. So high blood pressure, exercising, managing your diabetes, not smoking, all that kind of stuff. Part of the reason for this, and this is something we forget about a lot, is the brain this is a plastic rendering of an actual brain. It's the most vascularized thing behind your heart. And so every second, right now, you're getting blood pumped into your brain that's relying on baroreceptors in your neck to kind of keep that pressure sort of regulated. So there are, if you look in population studies, the areas that are the tail end of the arterial distribution you see white matter hyperintensities on the rim of the paraventricularly, the rim of the aqueducts, in like 95% of people, 98% of people. Everybody has some wear and tear in these areas because we're not meant to live quite that long, because we're not that constructed that way. So these areas, it's like getting hot water at the end of the plumbing. If anybody's had that happen in their house before, where it takes a little bit longer to get there. These areas are more vulnerable, and it's not unpredictable that you'd have some cognitive issues that go along with that. There's a bunch of evidence linking these in midlife, these modifiable risk factors, to white matter disruptions in the brain and other kinds of pathology. So this is in a recent study. I just want to pull up one because there's so many of these in asymptomatic middle-aged adults. So you can already start to see this building up, even though these are not people that have cognitive impairments. So to give you an idea why I think this is very important, so you've got the aging population, and you have some people who have cognitive issues. One of the things that's most elusive, and I feel like we rarely talk about, but clinically I cannot emphasize how often this happens. You have people come in who have what you'd call mild cognitive impairment, like pre-Alzheimer's kind of. They're amnestic, they have that pattern, they look like they're a dead ringer for Alzheimer's, they're on that path. That's a subset of the people who kind of come in. Most people who come in have something that's a non-amnestic kind of mild cognitive impairment. There's something going on. It's like what you mentioned, executive functioning. It's in an executive area. It's unclear the clinical significance. It might be caused by a myriad of number of factors. It's not Alzheimer's. It is impactful. And at a population level, most people won't have cognitive impairment from Alzheimer's. It'll be from cerebrovascular disease. It's just not as bad as Alzheimer's, and it's not progressive. But so at a population level, you have way more of these people that we don't even have good nomenclature for. They used to be called CIND, cognitive impairment, no dementia. Non-amnestic mild cognitive impairment terrifies patients because they search mild cognitive impairment and then they think they're going to have Alzheimer's, and that's not the issue. So these are more like inefficiencies. Cognitive frailty is not really a great term for that, but it's maybe something like that. So things like physical activity, comorbidity burden all kind of contribute to this. And then you have these individual differences that largely relate to different profiles of people coming in. People who come in and they're more amnestic. They cannot hold memories. That's who you worry about for Alzheimer's. People who come in and they're like, I walked into a room and like, what was I gonna do in here? Where are my keys? Kind of like, I missed the turn I was gonna take. That's much more common, much more tied to frontal subcortical functioning, not mesial temporal lobe functioning. Much more linked to cerebrovascular disease. Does that make sense so far? Kind of? Okay. So we've done a bunch of studies looking at provocative vascular measures and how those relate to brain functioning. A lot of these use these measures in the periphery where you blow up a blood pressure cuff, leave it on somebody's arm for 5 minutes. When you take it off, you can see how much the artery expands because of the blood rushing back through. You can do that from the brachial artery, from the forearm, and then there's an intimomedial thickness from the carotid artery you can get. So every 1/10 of a millimeter increase in this thing on the bottom right here basically doubles your risk of a stroke in the next 10 years. And in all the studies we've done, what we end up finding again and again is that basically age and sort of your cognitive reserve for education, that we're using in this case, are very strongly related to cognitive functioning, and then that provocative measure of endothelial functioning is the next best thing. So cardiovascular risk factors all relate to that. They all relate to in all the ways you kind of predict, but these sort of more sensitive provocative tests tell you something over and above those. In addition, I won't get into this too much, but there's sort of some microstructural and sort of macrostructural sort of interactions. So basically, even if you have clean arteries up here, if in your forearm, so the arteries that are out here in your toes and your hands and stuff are the most similar to the things that are going up into your brain in terms of the size. So even if you don't have sort of a big stroke risk factor here, if microvascular functioning isn't working well, you still have some risk. You can do this from a near-infrared spectroscopy, like sort of a poor man's version of the network stuff we've been talking about in an outpatient setting. To give you an idea what this looks like, you can do this like breath holding test. This signal change corresponds pretty well to a bold signal. It's basically like a stress test for hypercapnic response in the front part of your brain. So if you hold your breath, your brain will quickly recognize you need more oxygen, dilate in response to that, and you sort of see this increase. And what you see is things like being more overweight, out of shape, all these things kind of link to that measure and kind of the ways you sort of expect. Okay. Last one I'm going to talk about for risk factors. Obesity is also linked to poor cognitive functioning, not surprisingly. The mechanisms linking those are maybe a little bit different. It seems to be more insulin sensitivity and leptin insensitivity, if people have heard of those two. But basically, you can think about this as sort of your energy regulation sort of system. So this is closely related to vascular disease, but it's a little bit different. And this is part of the reason that you hear people talking about Alzheimer's as type 3 diabetes, where it's sort of the glucose insensitivity within the brain. Okay. And I don't know if people are people familiar with like long fiber pathways? Is this something everybody kind of knows about? Okay. I was going to say this is one of these things like I feel like between different disciplines sometimes we sort of like overlook. In the neuropsych area, we don't get into this until kind of like later in the neuroscience. I imagine you all are like looking. You guys have such pretty pictures. You might be looking at this in a more elegant way than we are. I think about these a lot because clinically, when you're seeing folks in a setting where you're evaluating them, like things like the digit symbol substitution test give you an idea of one portion of executive functioning. There's like 6 or 7 different versions of that where somebody can have some impairments, but it's in one sort of subdomain, like inhibitory control is bad, or working memory is bad, which tends to be sort of more dorsal. So you can have these different profiles, but I think part of this, or whenever I'm talking to patients, is because of these sort of long fiber pathways and how they sort of play out. So the main reason I'm emphasizing all this vascular stuff is not because it's because Alzheimer's isn't important, but if you look at post-mortem studies and like the slices of pie on the graphs down there, something like 80%, 85% of people have some amount of vascular disease in their brain if they pass away from another kind of pathology. So it's not the only thing going on. It's probably not the most important thing if you have something like Alzheimer's, but it's like it's an emollient. It's something that kind of pushes and amplifies the progression once you have that other pathology. Does that make some sense? Okay, cool. So I think about this in the same way that Professor Ted Lasso talks about it with his trainees. I don't know if anybody's Ted Lasso fan. Do you guys watch Ted Lasso? Anybody? Yeah, okay, all right, a few. So there's this one episode where he's talking about like all people are different people, which is like everybody's a snowflake. It's all different. It's great, but it's people. So people are very different, but they're not that different. So I like in this case, all people are different people, but it still ended up with him going out with another dancer and ended poorly, right? So you can kind of predict the same kind of convergent pathway of what's going to happen to somebody, even if the profile is a little bit different. So I'm emphasizing this because these kinds of inefficiencies or like cognitive frailties, whatever you want to call them, super common, can be impactful. They can look different across people, but they're more prevalent than you would think. And only a subset of people are going to go on to have Alzheimer's. Alzheimer's is more common in women. It's more common if you have a genetic predisposition for that. That's not actually most patients, but most people will have a cardiovascular risk factor of some kind that's going to have some progression. One other version of this, I'll just give you real quick. Russell Barkley has this idea that an extended phenotype of self-regulation, taking care of yourself. So for most people that I see in clinic, you see how you have these bottom parts, like they can inhibit themselves, they're working memory. That's like the base of the pyramid. So for most people, as you are developing, you get those subunits, then you can do the next step up. Once you got those, then you can do the next step up. Most people coming into clinic have an inefficiency at the bottom of the pyramid. They can do all the other stuff, they're very smart, they've got good problem-solving abilities. It's not the consistency in doing things over time. That's kind of where the issue is. And it usually results in one of these things at the bottom being inefficient due to the vascular stuff I'm talking about before. So I'm going to skip ahead just a little bit here. So yeah, you can think about this as an F1 car, like highly precise, versus sort of you're going on a dirt track, but you're kind of making it, but you're sliding all over the place, versus you're on the go-kart. With exercise and diet, and I'm just going to kind of breeze through some of this stuff. There are several different kinds of diets that have been explored. The two main ones are the DASH diet for hypertension and the Mediterranean diet, and then there's the MIND diet that's kind of emerging of the two. I think the main thing to tell you all about is that in most of the studies when we've looked at this is I think we've shown this in 3 trials now, and this is a 6-month trial of older adults with some cognitive issues. There's this additive benefit. So not a synergistic effect, not everybody's sort of having the same effect. It's if you can make your diet better, that's good. If you can exercise, that's good. If you're doing both, that's even better. You tend to see that some of these improvements are related to things like fitness, improved reducing your salt intake, improved cardiovascular risk factors. One of the biggest drivers seems to be insulin sensitivity. That seems to be a big driver, and this kind of makes sense. Even some of the meta-analyses looking at exercise and their improvements on brain function, they will report that the intervention works for improving brain function, but that VO2 improvements, so fitness improvements from those same trials, are not tracking with executive function improvements, suggesting there's kind of this nonlinearity and may have more to do with something like insulin sensitivity as opposed to just sort of your fitness level. So the other thing, I shouldn't put that up there, but I try to introduce Mike Tyson any talk I can whenever I have a chance, but the only other thing for mentioning this to you all, why it's important, is there's kind of this flywheel effect where executive functioning issues, they're different than memory issues because they tend to be important for how you are leading your life and regulating your life. It's much harder to get your diet good, go to all your appointments, take your medicines, if you are having difficulty kind of regulating yourself. Not to get into too many of the details, but there's a lot of also affective neuroscience kinds of literature looking at different sort of phenotypes of risk and how regulation is kind of a core piece of being able to do those things well. So just to sort of put it on your radar that there's this sort of feedback loop piece that's also kind of relevant. So you can have people in midlife where as their ability to regulate themselves gets worse, everything else we're talking about is also going to get worse. So those people might need more assistance for being able to kind of lead better lives in that way. To give you one example of this, there's a bunch of work. Early on I did some of this stuff, and there's a whole literature on vascular depression, but if you're not aware of this, for many folks, there's a subtype of sort of depression that seems to happen later, more among men and among people with cardiovascular disease, and relates very closely to the amount of vascular burden. So just to give you one version of that, where for some people they're coming off the rails a little bit. So just to finish up, these risk factors are very common. Cognitive dysfunction is diverse. Just remember, most people even going to talk a lot about Alzheimer's appropriately because it's can be catastrophic and we need treatments for it. It's not the most common type of cognitive impairment. So it's something that gets, to some degree, not overemphasized, but just remember there's a lot of other sort of inefficiencies or disruptions that we can potentially modify. Exercise and diet tend to have these sort of additive effects, and the other benefit is that this all helps with sort of your mood and keeping your life together. And with that, I'll stop there. Thank you.